So this talk is about how to assess fetal growth in twins and growth restriction. And it's again this concept of screening versus monitoring, which I touched on in the talk this morning about actually what we're really doing for TTTS. We're actually monitoring for the development of the disease. We're looking for the diagnostic features rather than actually screening. So again, when as part of the work that we did with NICE for the update for the guideline, we looked at all the screening markers or the markers that have been reported in the literature to screen or predict the development, growth restriction in twin pregnancies, and none of the reported markers would be good predictors, or, for example, according to NICE standards, would actually be recommended for screen. So, for example, the nuchal translucency, the discordance, or the discordance of the crown rump length, or the discordance of the fetal biometry in the second trimester, all of them will not really be good screening markers. And therefore, what we're doing is actually monitoring for the development of the disease. Are we monitoring that? By actually doing frequent scans in these pregnancies. And I show you the slides a few times between yesterday and today, which is the ASWA guidelines on the protocol for monitoring, ultrasound monitoring of these pregnancies. So dicoronary twins, we said that from 20 weeks, we're going to scan every 4 weeks, measuring the baby and looking for growth restriction, while actually in monocoronary twins, from 16 weeks will be every 2 weeks. And every scan, we're measuring the babies. And again, we said that a NICE guideline, which was published a while ago, about 8 years ago now, they said that we should estimate the fetal weight discordance. We actually calculated, so the estimated fetal weight of the bigger baby minus the smaller baby divided by the bigger baby multiplied by 100 to get the percentage, and we should do that from 20 weeks. The frequency of the scan should be at least every 4 weeks, and we did mention in monochorionic twins is moving to every 2 weeks. And NICE guidelines said 25% discordance would be the cutoff to refer this pregnancy to tertiary level fetal medicine center. But we also discussed the fact that when we looked at the data, one size does not fit all. The 25% might not necessarily be the ideal or the best threshold for example, a pregnancy at 34 weeks. Or at 28 weeks, because when we looked at STORC data, a large cohort of twin pregnancies, we found that actually the discordance, a cutoff that correlate or predict the risk of mortality actually varies according to the gestational age, and it tends to be higher at earlier stage, 28, 30 weeks, compared to a later stage in pregnancy. But also in the guidelines, you have to be pragmatic and you have to have a consensus. So sometimes it's easier to just have a one cutoff that all the clinicians can easily remember. And we also said, well, when you assess the biometry in twins, should we just maybe do the abdominal circumference? Is that better than estimated fetal weight, or just the head and the abdomen, or the head and the femur? And again, we said when actually look at all the published data, you need to use a formula to calculate the estimated fetal weight that includes 2 or more fetal biometry. So ideally, formulas that have the head, abdomen, and femur would actually have a better or more accurate calculation of the estimated fetal weight. And again, I showed you this data that we published in the White Journal, again, 5 years ago, when in a cohort of singleton pregnancies, more than 4,000 singleton and about 600 twins, they had the scan within 2 days of the delivery. And equation for estimated fetal weight at that point. And we did that for singleton and twins. So that answered a number of questions. Number one, it's confirmed that what we know, that the ultrasound is less accurate in twins compared to singletons. We know that. But also among these formulas, HADLOC2 formula had the best accuracy, and had the best accuracy either in singleton or twin pregnancies. And when we looked at the accuracy of the ultrasound scan estimation of the discordance, and again in the same cohort, so that they were scanned and delivered within 2 days, for a discordance of 25% or more, this AUC of 0.9 means it's very good predictor. Okay, well, since that, there has been a systematic reviews or meta-analysis that's been published to say, well, actually, ultrasound scan estimation of the of the discordance is not necessarily very accurate. But you have to be careful when you read the systematic reviews and meta-analysis, because it includes so many studies. Some of them, the scan was done many weeks before the actual delivery. Well, of course, it's not going to be that accurate compared to if you're doing the study, proper study, where you're actually looking at the scan. Within a day, the baby was born a day or two later. Yeah, so there is limitation, of course, to systematic reviews and meta-analysis. But if you compare the biometry in twins versus singleton, and we did that using a large cohort of ultrasound examination, about almost 10,000 ultrasound examination and about 2,000 set of twin pregnancies, you see that actually the biometry in twins correspond to the 40th centile in singleton at 18 weeks. That drops to the 35th centile at 25 weeks, and then drops to the 30th centile at 35 weeks. Again, that corresponds to what you know. Twins tend to be smaller than singleton. But also we found that monochorionic twins tend to be smaller than dichorionic twins. And therefore, what we did is that we used this large data to actually build twin-specific growth charts. So you have a dichorionic twin charts and monochorionic twin charts, and you have the charts for the individual biometry, so head circumference, abdominal circumference in female length, and also for the estimated fetal weight. And that's been published. And then it took us about a year to work with the ultrasound companies and ultrasound database to actually integrate that in Viewpoint or Australia, so that's available. And again, in the UK, that was funded by TAMBA, the twin charity in the UK, and have it on a free website that was funded by the Department of Health, that was used to actually have that accessible to everybody. And it's really easy. You put the gestational age in weeks and days, and then the estimated fetal weight by ultrasound scan, and it just gives you automatically the centile for this pregnancy. And also, I mean, in the UK, we do have hospitals in different parts, and some of them are quite small hospitals. And therefore, the midwife or the person who sees the patient don't have access to this ultrasound databases, and therefore they print the chart, they file it in the patient notes, and they plot the measurements. And that's, again, possible to download these charts. It's called twingross.co.uk. But actually, the concept of using twin-specific charts itself is quite controversial. Because some people would say, well, actually, twins are small because they are pathological. They have problems, and that's why they're small. They're not growing at the same rate as singleton pregnancies. And some other people would actually argue, say, well, they're small because they're twins. They're healthy. Why would you call them pathological? They're growing fine. They delivered near the end of the pregnancy. They did not have problems. And this concept, and at least in the UK, there was a bit of a debate on that, and therefore we published this paper, which is actually looking at the performance of these twin charts versus singleton charts versus the customized charts for stillbirths. And of course, the numbers are not big, because of the virtue of the fact that stillbirths is still small numbers in twins. But we found that actually the charts performed similarly to the singleton charts or the customized charts in identifying the pregnancies that had stillbirths because they were small, but actually labeled less of the twin babies as small. And what's the significance? What's the clinical importance of that? Is the fact that you're less likely to say this pregnancy is complicated by growth restriction or the baby is small, and therefore less likely to deliver iatrogenically. So you just deliver because you worry that this baby is small and not growing. So what are the diagnostic criteria for growth restriction? And it's really tricky, and it's really important to understand what you deal with. So there are a number of potential scenarios. One scenario, the common, is that both babies are growing, and the discordance is less than, let's say, 20%, and actually both of them, the estimated fetal weight above the 10th centile. Okay, but there is another scenario where actually both babies, they have estimated fetal weight less than 10th centile, and maybe there's no big discordance. There's another scenario that actually one baby is less than 10th centile, the other baby is above 10th centile, but the discordance is not that big. Or there's another scenario that actually both of them are small, but they have big discordance. So there are different scenarios. And therefore, it's really important that you have a diagnostic criteria. You say, okay, well, this pregnancy have this, that fits with this complication, and therefore the pregnancy is labeled as this complication, and therefore you know how to manage, and you have protocols how to manage and counsel these pregnancies. And the problem, when we look at the literature, there's huge variation in what people would call selective fetal constriction. Some studies would just say 1 baby is less than 10 centile, regardless of the discordance. And that's, for me, I think that's a big problem, because the 10 centile depends on which chart you use. If you use a singleton chart, maybe it is less than 10 centile. If you use a twin chart, maybe it's actually above the 10 centile. Yeah? So that's why when we wrote the ISWAC guideline, I said that it involved a lot of really fantastic experts. They said, well, in a dichorionic twins, just treat it as singleton. So 1 baby less than 10 centile, that would be selective fetal constriction in a dichorionic twin. Well, actually, if you have a monochorionic twin pregnancy, you have 1 baby less than 10 centile plus a discordance of 25%, but also highlighting that if it's 20%, you should really monitor this pregnancy carefully, because it's still at risk. And therefore, because of this huge variation and letters after the publication, there is a guideline highlighting that people we use different diagnostic criteria in different studies, and therefore you can't really compare the studies. You can't compare the outcomes if the definition in the first place was different. So this Delphi that we did, which just to reach a consensus, and I showed you that the experts decided that you have a solitary definition. If 1 baby less than 3rd centile, that would be enough to diagnose selective fetal constriction. Or if you have contributory diameter, so if you use less than 10 centile, you need to have, in addition, you have discordance of 25% or more, or abnormal umbilical artery Doppler, which you can say it makes sense, yeah? But as I said, for me, I think I'm struggling with this less than 10 3rd centile, because number one, most to at least the viewpoint, it just tells you less than 10 centile. It does not tell you that it is less than 3rd centile. And that varies according to the chart that you use. While actually doing the less than 10 centile with a discordance of 25%, I think it's just more practical, and it just makes sense to me. And certainly I think it's the commonest that's used, at least in Europe. So how should we manage these pregnancies? And as I said, the ISWAC guideline, they said, well, there are no randomized controlled trials. There's no really clear guidance like the TTTS when you know that the laser is a first line, because that was done in a very good, high-quality studies. We don't have that in fetal constriction, neither in dichorionic nor in monochorionic twins. And therefore, they said, well, just in a dichorionic twin pregnancy, you should manage selective fetal constriction as what would you do in singleton. So in terms of looking for features or the Doppler changes that are predictive of the risk of stillbirth and deciding when to deliver. However, for dichorionic twins, it's not as straightforward, because you have another baby that's average size, normal Doppler, this baby is growing fine. And therefore, you really need to do your best to avoid delivery before 30 weeks, because of the risk of prematurity to the other normally growing baby. And therefore, before 30 weeks, we would do our best. We would advocate expectant management and monitoring. While after that, there will be thresholds for delivery. So for example, if you have reverse ductus venosus in the reverse A wave in the ductus venosus, the threshold to deliver will be about 30 weeks. Sometimes we will go maybe 29 or 28 weeks. It varies from the centers. And if you have an abnormal or reverse endostolic flow in the umbilical artery, would consider between 30 and 32 weeks. If you have absent endostolic flow in the umbilical artery in the smaller baby, will be about 30 to 34 weeks. But certainly after 34 weeks, the threshold is much less. So even if you have normal umbilical artery Doppler, but you have low middle cerebral artery pulsatility index, for me at least, that would be a threshold to deliver this pregnancy after a course of steroids, of course. What about in a monochorionic twin pregnancy? Would the management tend to be according to the umbilical artery Doppler? Because there's a Graticus classification, which is type 1, type 2, type 3. Type 1, when you have positive endostolic flow in the umbilical artery, and I said that tend to have good prognosis in the majority of the cases, with a low risk of demise of the smaller baby. Type 2, when you have absent or reverse endostolic flow in the umbilical artery, worse prognosis with increased risk of demise of the smaller baby. And type 3, when you have this intermittent absent or reverse in diastolic flow and umbilical artery. So quite characteristic pattern. Almost you need to look for it. And as I said, in my experience, it's quite rare. It's not a common type. So when we looked at our data, and we published this, I think, about last year, we compared type 1 and type 2. We didn't really include type 3 because there were few numbers, a small number of cases, and we looked at the progression. In our series, it was about 20% progression in type 1. That's probably higher than what's been reported, but perhaps because if you work in a referral center, probably the type 1 that you see are probably the complex type 1, not really just of the older type 1, because probably the people would refer cases to you when they think that there might be severe cases. For type 2, we had 34% progression. And how do you actually define progression? So also the instance of progression will vary according to your definition. How do you actually define that this case have progressed? So for example, for type 1, with worsening, if the umbilical artery from positive becomes absent or reversed, while type 2, which is already absent or reversed, in this case, we rely on the ductus venosus Doppler. So how do you identify the pregnancies that are risk of intrauterine demise among those who have selective fetal growth restriction? And certainly the two important parameters would be the gestational age of diagnosis. The earlier the diagnosis, the higher the risk of demise of the smaller baby, and also the ductus venosus Doppler. So the ductus venosus Doppler is, if it becomes absent or reversed A wave, that's a strong marker of the risk of demise of the smaller baby. And then in 2017, this meta-analysis was published in the White Journal, which what they did, which was quite nice, is that looking at the outcomes according to the type, with a type 1, type 2, and type 3, because you need to tailor your counseling according to the specific condition that you see this woman. And the counseling obviously would vary so much between type 1, type 2, and type 3. So in this meta-analysis, this was a progression. So about 15% in type 1, about 60% in type 2, about 10% in type 3. And you can see the gestation age of delivery, which again consistent with the data that I showed you earlier, but also consistent with what we found in our data. Type 1 about 34 weeks, type 2 about 31, and type 2 about 33 weeks. This meta-analysis also looked at the risk of perinatal mortality and morbidity. And again, you see in type 2 and type 3 tend to be higher than type 1. But just again, with this meta-analysis, you have to take the data with a pinch of salt. You have to be careful because a lot of this data tend to be biased because the numbers of the studies are small and each study have small number of cases and tend to be observational, tend to be retrospective, and therefore the quality of the data is not great. So in a monoclonic twin pregnancy that's complicated by selective fetal growth restriction, it's really not easy because the risk, if the smaller baby dies, there's consequences to the other baby. Remember, we said 20 to 25% risk of demise or brain damage to the co-twin. And therefore, there's only three options. Option number one, just to monitor and don't do any intervention, but likely to deliver early. Option number two, doing active fetal intervention in the form of laser, which technically tend to be quite difficult, not easy, not straightforward. And the third option is to do selective termination or reduction of the smaller baby, often by cord occlusion, but also you could do other methods like what we discussed yesterday. And then what we did is that we built on the other meta-analysis. Other meta-analysis was just reporting according to the type of selective fetal growth restriction, the Kratakos classification, but we also wanted to actually to have the outcomes according to the management of this pregnancy, whether these pregnancies were managed expectantly, or whether they were managed by laser, or whether they managed by cord occlusion or selective termination. And there's so much data in this meta-analysis. It's published, you can read it, and I'm just going to show you some of this data. And the way I put it here is just easy for us to understand, and also if you want to use these figures for counseling. So you see type 1, type 2, type 3. And each one, you have the three options, expectant in black, laser in blue, and the cord occlusion in red. And what it shows you here clearly, so for example, in different outcomes, so the intrauterine demise, and the next few slides, I'll be showing you different outcomes like the survival, intact survival, risk of neonatal morbidity, and brain problems. So for example, here in type 1, you see the risk of intrauterine demise with type 1 is very small. And actually, certainly, but when you do laser, it's higher. So you can't really justify, based on that data, you cannot justify doing laser in type 1 selective fetal constriction. But even in type 2 and type 3, you see that actually laser have higher risk of demise of these pregnancies. Cord occlusion have low risk, but by definition, when you're doing cord occlusion, your denominator is less. It's already 1, it's not 2. So you have to take that into account. What about neonatal deaths? Again, sort of it's very low in type 1, and again, type 2, you see that the laser is actually associated with higher risk of neonatal deaths. Survival of at least one baby, again, very high in type 1. And again, that's based on this data, you cannot justify doing any active fetal intervention in type 1, just monitor, really, expectant management. But also it shows you that actually the survival of at least one baby, even in type 2, is quite high. And certainly in, for example, the pattern that you see that perhaps actually the survival is quite high regardless of the intervention. It's not that low. The overall morbidity, which is interesting because you see that actually the laser tend to be associated with lower risk of morbidity. So you see a pattern that maybe laser is associated with higher loss, but maybe reduction in morbidity. So that's intact survival, and that's live births. So live births, type 1 high with expectant management, which is good. Type 2, you tend to have higher live births with type 2, with expectant management, the cord occlusion. But remember, we said cord occlusion is you're already removing one baby, and laser have actually lower live birth rate, according to this data, in type 2 or even type 3. What about abnormal brain imaging? So it seemed that there is a pattern that perhaps maybe laser might have a protective role for these pregnancies. While actually type 1, as I said, the risk is very small, and therefore you probably don't justify any active fetal intervention. It's not needed majority of the times. So from this meta-analysis, just to summarize really the key findings, type 1 have good perinatal outcomes and usually managed expectantly. Type 2 and type 3, laser tend to have higher mortality, but perhaps lower morbidity. And therefore, if you have a pregnancy that's very early gestational age, maybe you would consider active fetal intervention, but certainly at a later gestational age, perhaps you don't really need to consider active fetal intervention. And therefore, when you manage these pregnancies, it needs to be individualized, take into account 3 important parameters: gestational age diagnosis, because certainly if it's a late, certainly after 24 weeks, probably, most likely, you don't need to do any active fetal intervention. And I think expectant management is usually okay in the majority of these cases. The severity of the gross discordance and the magnitude of Doppler abnormalities, which determine type 2 and type 3. So ISWAG, which was published about 3 years ago now, we did not really have this data from the meta-analysis, but certainly there was a consensus about how often do you see these pregnancies and when is the gestational age that you should deliver. That was a consensus based on experts, not based on randomized controlled trial or high-quality evidence. So in dichorionic twins, at least every 2 weeks, as if it's in singleton, for example, cross restriction in singleton pregnancies. In monochorionic with selective fetal constriction, at least weekly, maybe even more. Depends on the type, it depends on the Doppler findings. And then if you reach a situation where you think that there is a high risk of demise of the smaller baby, for example, if you have abnormal ductus venosus, the management would depend on the gestational age. So if it's beyond 26 weeks, you really should consider delivery after a course of steroids in a hospital where you have a neonatal center that can look after very early babies. Before 26 weeks, I think the outcome would be likely to be guarded if you deliver early, because the other baby, the normally grown baby at less than 26 weeks, is a very high risk of neonatal morbidity and mortality, and therefore this is the cases that you would consider active fetal intervention. When should we deliver these pregnancies? The consensus for type 1, where the prognosis is very good, usually about 34 to 36 weeks, while type 2 and type 3, I say maximum, most people would bail out at about 32 weeks, but obviously if there are signs of deterioration, perhaps earlier than that. And that would be, I'm sure that would create a lot of discussion and debate. But sometimes, from the clinical point of view, sometimes you have this woman where you have a discordance in amniotic fluid, discordance in the size, but it's not really bad enough to actually justify diagnostic criteria for TTTS, and also it's not really bad enough to justify diagnostic of selective fetal constriction. And some of these pregnancies will go on and develop TTTS and become very clear, but some of these pregnancies, the discordance, you never get polyhydramnios, and it becomes clear that it's actually a case of selective fetal growth restriction. The other thing as well is that sometimes with selective fetal constriction, you're following up and then suddenly you have TTTS, and therefore in these cases the management is very clear-cut, will be the management of the TTTS. So it would be the laser, for example, because now it's a TTTS superimposed on selective fetal growth restriction. And therefore, from the practical point of view, how do you differentiate between TTTS, which is often chronic disease that develop gradually, versus acute TTTS versus selective fetal constriction? Well, of course, in the classic TTTS, you have discordance in the polyhydramnios, oligohydramnios sequence. Often you will have discordance in the size as well. For acute TTTS, you will have the polyhydramnios, oligohydramnios sequence, but often there is not large discordance in the size. Often the two babies are relatively similar size, while actually selective fetal constriction, you do not have polyhydramnios, so baby that have normal amniotic fluid, and the other one have oligohydramnios, and you have a big discrepancy or discordance in the size, with one baby being small. But if you look back sort of at the old literature and the initial studies from Lisbeth Louis, where they actually, and I just show you this slide to reiterate the importance of the gestational age diagnosis, because I think we're so much focusing on the Gratakos classification, type 1, type 2, type 3, but actually there is really a very important role of the gestational age diagnosis. If it's an early onset, often they tend to be quite severe, often the outcomes, there is increased risk of demise, 20%, while actually in the late cases, when you have a discordance after 26 weeks, the majority of these pregnancies do very well. The survival rate is really high, but be careful because of the risk of TAPS, twin anemia polycythemia sequence in these pregnancies. And therefore, you should be looking at the MCA peak systolic velocity in these pregnancies, not just the follow-up of the after the laser for TTTS. So the last couple of slides about selective fetal constriction in triplets. And again, remember we said that triplets with shared chorionicity, either they're going to be dichorionic triplet or monochorionic triplet. And you see that the difference, that the survival rate obviously tend to be less if there is the monochorionic. So you see that at least one survival. It's about 70 to 80%. All survival is only about 50%, so really the outcome is not great. And the smaller twin, the chance of survival in dichorionic twins is about 7% compared to 40%. That's at least what's been published in the literature. And again, just the survival rate and the risk of preterm delivery in a dichorionic triplet, if it's complicated by selective fetal constriction, compared to if it's complicated by TTTS. And what's interesting to see that the survival tend to be less in cases with selective fetal constriction compared to TTTS, which is quite surprising for me. And actually the preterm delivery, less than 32 weeks, was actually higher in the TTTS compared to the selective fetal growth restriction. So really the take-home message, we really need to try to use a uniform standard definition of selective fetal constriction. We need to stop what's happening now in the literature, which different studies using different definition, impossible to compare, impossible to actually combine the data. The survival of selective fetal constriction differs according to the type, and I showed you this data. The risk factors of demise in these pregnancies would be mainly the gestational age and onset and the fetal Doppler of the smaller baby. If you have a TTTS, it doesn't seem to influence outcome, but if there is a TTTS, you should manage as TTTS, so laser. Consider early referral to a tertiary fetal medicine center because these pregnancies tend to be quite complicated, and as I said, the evidence in the literature is limited. You should balance the risk of intrauterine demise versus prematurity, and therefore don't deliver really early. Certainly avoid delivery before 28 weeks because you avoid the risk of intrauterine demise, but you will actually on the expense of significant risk of prematurity. And as I said, the comparison survival according to treatment using observational data is likely to be biased. And this is what we found in a systematic review, really quite limited. Really, I don't think the data there is very reliable. And I'm going to stop here. Thank you. Okay, questions or comments? Lisbeth.
Thank you, Asma, for the clear presentation, because selective IGR is just one of the things where we don't know what is best to do. I just want to make a comment and stress that when you want to pick up the type 3 cases, you really have to sample at the cord insertion, because otherwise you will miss them. You will think it's a type 2, whereas if you sample at the cord insertion at the placenta, then you will see the intermittent pattern, because otherwise you will miss it completely.
Yeah, you're right. But the other thing as well, which we've been seeing, because we're looking at the data, is actually the pattern of the Doppler itself changes. So today, for example, there is absent diastolic flow. In next week, there is positive in diastolic flow. Today, there may be this pattern of intermittent. The next week, you look really carefully on the placenta and you don't see it anymore. So, and therefore, I think that's one of the, problem or challenges of counseling and management based on the Graticus classification is that this Doppler findings, the majority of the times is consistent, but sometimes they vary from one week to another. And in these cases, funny enough, I tend to manage on the better Doppler. So for example, if it's today was absent and next week is positive and next week is absent, I would tend to be a bit more positive in my counseling than if it's persistent negative.
Yeah, but yeah, because indeed it's important, because I think that type 2 cases are the potential cases where we would consider doing laser surgery and doing a trial. But the type 3 cases, I think if you do laser, it's almost 90% chance that you will lose the smaller baby, because these are the unequally shared placentas with huge anastomosis. So also your laser surgery is likely to fail. So maybe, we should fine-tune our diagnostic criteria for type 2, but at least I think sampling at the cord insertion is very important to pick them up. And then maybe think about a trial for these type 2 cases where you think that the donor baby or the smaller baby is likely to die, the ones with the abnormal duct. I don't know, Kurt, what your thoughts are.
Well, in type 3, I would never do a laser or cord occlusion. I just wait until 32 weeks and then deliver.
Yeah.
Yeah. And Asma, you mentioned that if you do a cord occlusion, your denominator is only half.
Yeah.
In terms of mortality. But I would even go one step further. You have to include the iatrogenic mortality in your overall mortality, because you just kill one.
Yeah.
So the best you can achieve is a 50% survival rate, and then which has to be lower than if you do a laser, by definition, or you just wait.
Yeah.
So even I'm very hesitant to do cord occlusion in selective fetal growth restriction. Only if there is a twin-twin transfusion syndrome, then you do a laser and you see what happens.
Yeah.
And I always explain to the parents that your risk or likelihood that the smaller baby will die is about 50%.
Yeah.
In those cases. So.
Yeah. And to be honest, also we didn't really touch on ethical point, of course, because that's from my experience, I think a lot of parents do not opt for the option of selective. I think just to get the parents to decide and prioritize one baby over the other in a baby that does not have abnormality, in a baby that you're not really certain that there will be a risk of disability in the future, I think it's very difficult for the parents. And many parents would say, I cannot choose, I cannot make this decision, I would just carry on. I give both of them a chance. It's really difficult for them.
But the thing is, I think we should discuss it, that there is the option, because obviously not all parents want, if you have a type 2 selective IGR diagnosed at 20 weeks with really a very small baby, then, I mean, they're looking up to delivery around 30 weeks. And obviously there's a risk of neurodevelopmental impairment that is not well documented. So some parents would then opt for a termination, for a selective reduction, and having a pregnancy that is like a singleton pregnancy with a birth around 36, 37 weeks. So I think, we should discuss it, that there is the option of in these severe type 2 cases.
Yeah, and certainly, I mean, there is, some studies from the French group, so like, for example, Yves Veil, where they publish on their experience on cord occlusion in these cases, and I think that's, for them, that's a valid option. We had a debate in the fetal medicine FMF conference. Not a debate, we had like just really the experts in all over the world. And it was really nice to see that there's a huge difference in opinion and the management of these cases. And each person have their own experience. And so of course you have to respect their experience. They're talking from experience. But it was clear that there was no consensus. There were some strong opinions as well. But I don't know, for me, I'm more sort of what I'm really trying to do, because we cannot do anything about the fact that we don't really have evidence. We just need people to try to get the right trial, the right research question, and get a good quality to answer it. But I think for us, what we could do meanwhile is to just try to standardize the way we diagnose it, so that we have consistent, so we actually talk in the same language, and we including comparing cases the same in this center at this center, because at the moment they're not the same. Angie.
Just another couple of small questions. Are there any practical differences in how you laser for selective growth restriction when it's its own entity without coexistent TTTS? And also, is TAPS a feature that you've seen post-laser for SIGR? Or is it something that we don't really notice?
Okay, so I think the laser is much easier for TTTS, because number one, you go in the sac of the recipient, you have polyhydramnios, and often the equator, if you plan it properly, you can see the equator clearly, the placenta, because the polyhydramnios, the placenta is quite thin, while actually in selective fetal restriction, I think technically it tends to be more difficult, because there's no, the other baby is not really completely stuck, and you don't have polyhydramnios. I think it's more difficult to make sure you got all the equator. I think the risk of demise of the donor is higher. For both laser TAPS, I don't think there are many cases reported in the literature for both laser TAPS for selective fetal restriction compared to TTTS. I think the majority of the cases that are reported is after laser for TTTS. But there are cases where even without any active fetal intervention, there are TAPS in selective fetal restriction cases. And I showed you a case yesterday where it was selective fetal restriction, TAPS, and there was brain abnormality. I mean, I don't know whether you have different experience, Lisbeth or Kurt or Monique, about laser technique for selective fetal restriction compared to TTTS.
I don't have a different experience, because we just don't do it.
Yeah.
We don't do it. We tell people you don't have to refer them for laser. You can refer them for to look at them and monitor them, but not for laser. What about you?
No, we neither. We don't do laser for SIGR. I think one or two cases which we did, because there was really, it was so severe that there was an indication for cord occlusion, but patients refused cord occlusion, so it was an intervention to protect the bigger baby from, that was the only acceptable intervention for the patient, but that is only 1 or 2 cases.
Yeah.
Very, very, very small, not reaching viability cases. So I think we did 1 or 2 in our center, but that is absolutely the max.
In actual fact, for the cases with early fetal growth restriction, monochorionicity is of benefit to the smaller baby. So if you abolish monochorionicity, it will die and you have a higher risk of intrauterine death. So, okay. So what? Well, there's no improvement. I mean, unless they develop TTS, then you do the laser, of course.
Okay, yeah. Yes, please comment from Spain.
I have a comment. I think it's really difficult the counseling in these cases because for us that we come from different countries, the preference of the patients are very different. So, for instance, in Spain, like if you say like morbidity and there's the chance of one baby having brain damage and the other one no, I mean it's easier. Well, people tend to prefer the cord occlusion than what is that you did. So it's really difficult to have a very huge consensus about these things because if you ask to the parents, the cultural differences are huge in every country, I think, in my humble opinion.
Yeah, you're absolutely right. Yeah. But also the legal, the regulations will be different in different countries. Yeah, but even the woman, yeah.
So about the study that was checking the effectiveness of laser treatment in selective FGR cases, maybe actually the increase of the fetal mortality is the explanation of improvement in fetal morbidity? Because if the most affected babies cannot go through the operation.
Yeah. Well, you're probably right. You by virtue of the fact that the babies that have, that they're likely to have bad morbidity, died because of the laser, the fact you're improving the morbidity.
I tell you why they die. Because they are left with a pathetic part of the placenta.
Yeah.
If you look at those placentas, they have 20% and that's why they die, not because they are ill in the first place. They die because they are just cut off their their nutrition.
Yes, but I don't think his question was asking about that. His question was saying, do you think a potential explanation of the improved morbidity with laser, the fact that they actually have higher mortality? So the babies that would have had bad morbidity because you deliver them early, actually you reduce them because they died after the laser.
Yes.
It's just explanation of the results rather than the pathology, I think. Am I correct?
But for that, to have evidence for that, we really would need a randomized
Correct,
trial.
absolutely.
And that
We
would
need
be
an
very
RCT.
difficult to perform.
It's very difficult, yeah. It's proving very challenging.